Thank you. I'm actually delivering my name's Carolyn Deforge. I just came onto the NAC in April. I'm just finding my feet. I'm a bit nervous about standing up here actually, because I've not done it in front of everybody here before, but it is nice to be here, and it's been a very interesting and enjoyable 6 months so far. I'm actually presenting Dee's talk for her, so I'm going to read it because she's got some very specific things she wants to say. Knowledge is power, information is liberating. Some of you who came to NACAC in 2013 will recognise this quote from a talk from Dr. Dee. This is an update on the ongoing work since and will take about 20 minutes. The talk is split into two sections. Firstly, the projects and research that have been done and are being done to develop the Trust's knowledge on health issues affecting you. And then, most importantly, how the Trust uses that knowledge to help you. I'm not going to take question and answers at the end of this because obviously it's Dee's talk, but she says please do email her or give her a ring later on. So firstly, what projects and research are being done to help our knowledge of the issues that are affecting us? You may already know of some of them, particularly if you've been to NACAC before or you've been reading about them in the Trust and the NAC newsletters. If I look first at projects around the world, there are two in particular that the Trust have been following. The Trust has long been aware of issues we face with trying to control weight and trying to find suitable exercises. We know weight gain is even more of an issue as we get older. We know that the more weight we carry, the more difficult it is for us to get around, and this makes any existing disability from thalidomide even worse. We also know that some of us don't know how to exercise safely. 2 years ago, the Trust became aware of a project in Sweden on managing lifestyle by exercise and diet and its effect on pain. After looking at the project, the Trust decided it was a very worthwhile project and that it would follow the project together with the NAC rather than do any of its own in-house research on these issues. The Swedish team came over in April and presented their findings to the Trust Health and Wellbeing meeting. More of this later. The second most important recent project has taken place in Germany. Again, you may well have heard it. It's known as the Cologne Report, or more accurately, the North Rhine-Westphalia study. The study's purpose was to see how best the German health insurance system and care system could provide for those affected by thalidomide in the future. This was a very large project involving 200 people affected by thalidomide who filled in questionnaires, were examined and had scans or x-rays. It looked at the damage the individuals were born with, but also any secondary damage that had occurred with age. Very briefly, the results were: they felt that doctors and carers were not properly informed about thalidomide and its effects. In particular, they felt the doctors were not respecting that many affected by thalidomide do not like taking tablets, and therefore they don't like taking painkillers because of the thalidomide and what it had done to them. And people needed more reassurance to take tablets. They felt the doctors weren't prescribing enough physiotherapy, massage therapy, or pain relief. They felt these therapies should be available during a stay in hospital to help rehabilitate them. They felt their care system was not prepared for them as they grow older and have increasing needs. Interestingly, a large proportion, 80% of the group, were actually working, but only 50% had work adaptations in place. They felt that not enough was being done to help them with work. They felt they needed to identify the people who are more vulnerable, encourage lifestyle alterations to prevent further damage, train doctors to help individuals understand the need to take tablets, particularly painkillers. They also felt doctors should be able to refer individuals more easily for gadgets and gizmos, that individuals should find it easier to get financial help with health costs and have a better awareness of mental health issues. So what did the Germans decide to do about it? Well, the project resulted in a fund being set aside to which individuals could apply with attached criteria. For example, identified therapies, massage, physiotherapy, also aids and adaptations for gadgets and gizmos, as HealthLink calls them. It resulted in the setting up of more specialised centres where doctors could receive specialist training in helping with pain, together with the facility for a stay in hospital for physiotherapy, massage and acupuncture. So, if I turn back now to the Trust and the projects in the UK. Firstly, the nerve study. You should all be aware of the nerve study with Charing Cross. We were sent a letter about it with the results of the study. Since that time, Charing Cross has been trying to get the paper published. It was suggested they did some more work on it to make it more robust. The Trust had questions about their work, and until the paper is published, the Trust cannot openly discuss the work with other people. So the Trust requested their own independent review from a very knowledgeable doctor at Oxford University. Importantly, the review agreed with the study that if you have pain, pins and needles, numbness, then it is important you go to your GP and be referred to find the cause. This is because it's very likely the cause may be a trapped nerve that could be freed. For example, carpal tunnel, where the nerve is trapped in the wrist. However, 2 individuals have had trapped nerves in the neck and needed an urgent opinion to prevent serious long-term damage. Australasia has since published a paper saying exactly the same things. The review from Oxford on the Charing Cross study did differ to some extent. It differed with respect to the fact that the Trust had wondered if we might have a condition similar to what happens to individuals who contract polio. Polio causes paralysis where the motor nerves are affected and the muscles don't work. So initially an individual may not be able to move their leg. The individual then recovers to some extent. For example, they could move the leg, but the muscles are weaker and they may have a limp. However, as the individual ages, the body cannot maintain that recovery and the nerves get worse. Again, this condition is called post-polio syndrome. However, the review did assure the Trust that this condition is not happening in ourselves. The nerves controlling movement are not affected. So that's very good news. If you remember, our letter said that there was some possibility of an underlying nerve problem as we aged. This is because the study looked at individuals with damaged arms but relatively normal legs, and some of the nerve tests in the legs had come back abnormal. The review did find some evidence that nerves they tested in undamaged legs were affected. However, the review felt it was not possible to know whether the individuals had been born like this, which could be the most likely explanation, or if in fact the nerves had changed with age, which the study had focused more on. Hence, the review suggested the conclusion was changed, suggesting there was only some evidence of a problem with nerves as we get older. Dee says this may be hard for us to understand, but later in this, the talk explains what the Trust are doing about it. Another project is blood pressure recall. The Trust Blood Pressure Project with Professor Williams and his team at University College London, I'm going to call it UCL from now on. If you remember, this is to help those who cannot have blood pressure taken in the normal way with a cuff in the upper arm. It is also for those who may need more reassurance as the need to take tablets for life to help blood pressure and prevent a heart attack or stroke. Where are we now? This study has ethics approval, and this makes it safe and fair to ourselves. The study has also received a national stamp of approval and has been included in a national set of studies thought to be very important in helping care for the general population of patients. We have agreement from the health departments of England, Scotland, Wales and Ireland that your GP can refer us on the NHS to the clinic in London if we meet the criteria for this study. Some individuals have been referred by their GPs with the help of the Trust to be the first ones through the clinic and study. They will help us make sure everything runs smoothly, that the accommodation is okay, and that all the tests can happen in one day. So they're like the guinea pigs. The start of the study has been very delayed. UCL told the Trust it was because they were moving the clinic and this would make it much better. And they also had to coordinate our research with other studies they were also doing. Once UCL have seen these individuals and we know it's working well, we will openly write to you all and invite you to take part and explain how to do so. This is if we meet the criteria and live in the UK. I just wanted to remind you of the importance of the study, the stamp of approval it has, and that other countries are waiting for the results to see how they can help their own individuals. Please remember this when you receive the invite and are considering whether or not to go. Another project, the Upper Limb Project. Again, we may have heard of this project before. The project was to help individuals who had difficulty obtaining a diagnosis on their arm pain, either because the GP would not refer them, or because the GP didn't know who to refer them to, or they felt they had an opinion and needed more reassurance as to whether or not to trust it and take it further. Hence, the Trust funded a private opinion and tests with Professor Trail at Wrightington Hospital, so that a diagnosis could be reached and that options for treatment could be discussed. All those who fed back said it had been very worthwhile and wanted this to be available to other beneficiaries in similar circumstances. The Trust has continued this project on looking at all thalidomide damage and where best individuals can get to help. Another project, Dr. Cowan. Last year, Dr. Cowan from the Royal National Orthopaedic Hospital just north of London gave a talk at NACAC here. Dr. Cowan is a very eminent bone and nerve doctor specialising in helping those with difficult problems. The Trust involved Dr. Cowan because individuals were telling us they were concerned they had underlying issues they felt might be due to thalidomide, and because other countries were looking at specialised centres, and we wondered if we needed one. Dr. Cowan has been seeing anyone who wishes to go and see him with help from HealthLink. So, how can he help? He has helped individuals sort out their own issues, to talk them through, and if needed, advise their GP what tests to do, and for the individual to have them done near to where they live. He has also suggested treatments to help lifestyle advice, such as found within the Swedish study with exercise, but also physiotherapy and rehab programs, again, to be provided locally near where people live. He is able to provide a stay in hospital for physiotherapy, etc., similar to what the Germany is setting up. However, he has not actually felt the need to suggest this, or if he has, the individual has not wanted to access it. He has specifically helped the more severely affected in the group with more complex conditions that the Trust and GP have been very concerned about, not necessarily with limb issue problems. He has sometimes requested the GP refer the individual on to other specialists familiar with thalidomide limb damage with the help of the Trust, such as shoulder specialists, wrist specialists, often within the RNOH, his own hospital. He cannot find any underlying common issues amongst us all that require a specific specialist centre outside the ones that have already been identified. If you remember, I mentioned before the nerve study that they'd wondered if there was some possibility of an underlying problem with nerves. To remind you, this is because some of the nerves in the undamaged legs were abnormal with special testing. Dr. Cowan has not done tests, but he has looked to see if the nerves are causing any problem. This means he's asked specific questions to see if the individual has any symptoms and checked to see if the nerves are working properly on examination. So far, both these areas, the nerves are working fine. This is very good news and supports the nerve study review findings that it is more likely the specialised testing of the nerves in the legs showed problems that had actually been there since birth, rather than the nerve study findings where the nerves are getting worse with age. Sorry, that's a bit complicated. So basically, any problems with the nerves are there from birth. They're not being acquired as we get older, which again is good news. Right, I've gone through how we develop our knowledge of the issues that affect us all. Now, I'm going to explain how the knowledge that has been acquired through this research is being used to help us. And as said, this is the most important area. I've explained how weight and exercise have long been issues known to the Trust. So how does the project on the Swedish lifestyle and its effect on pain help you? Well, the work is being used to underpin the Fit for the Future event that is being held by the NAC in April next year. And Simone's going to fill us in about that later on. There's a lot of hard work being done on that. The book they used is freely available available free of charge via the internet. And do you know what? I'm really annoyed because I've got a copy at home and I meant to pick it up and wave it at you. But it is very good, so it'd be worth looking it up on the internet. I found it really interesting. And if you wish a link to this, please email the Trust. It is a very good read. It's very clear and easy to follow.
What was the name of the book?
Do you know what? I can't remember what it's called. Simone,
I've got a copy.
You've got a copy?
If anybody wants to look, and the recent NAC newsletter that went out also had a link to where you can view it.
Fantastic. Maybe, Simone, after lunch, do you think you can get it at lunchtime and we'll sort of wave it around for people to look at, okay?
I want it to wave around in my speech.
Oh, right, okay. We'll wait for her for Simone to wave it around. Okay. How are we using the Cologne report information? The Trust has liaised with the authors of the report and paid for an English translation. This has been agreed with Germany. As soon as the report is openly published in Germany, the Trust will put it on the website, so any of us or any English-speaking healthcare professional abroad who wishes to read it can do so. So, I've given you already a summary of the main findings of the report. They said specialised centres, a fund for physiotherapy and gadgets and gizmos, having more informed doctors, better able to help with pain. So how does this knowledge fit with what we're doing here? From our questionnaires and Dr. Cowan's work, individuals in the UK prefer physiotherapy, massage and rehab programmes near to where we live and not in a specialist centre. We don't want to travel miles for it. Dr. Cowan does not see a need for such therapies to be in a centre, but his own hospital already can provide for this and other conditions if a particular individual needs to access this. We are lucky enough to have the health grant, which, as mentioned, I think it was actually in the finance one, can be used for private physio and massage on top of what the NHS can provide, and gives us a much wider choice for what it can be used for other than the specific fund that they are recommending in Germany. Nearly at the end. It will advise you whether or not we need to take... Have I gone to the right page here? Sorry. Sorry, I forgot to turn over. We have much knowledge in the trust of thalidomide and its damage, and we have very experienced specialists in certain hospitals we work with who are already familiar with thalidomide and how to help. For joint and spine issues in particular, we work with 2 hospitals. If individuals are prepared to travel, and these are the RNOH already mentioned and the Wrightington, where the upper limb project took place. Where we suggest for other thalidomide damage varies as to where the best experts are. Hence, we feel the areas raised in the report have already been looked at within the Trust and will continue to be. For example, there's always ongoing work around pain and how to help it. We also await the Firefly report from the questionnaire that over 75% of us have recently filled in, and we will revisit the above areas if necessary. How do the results of the nerve study help us? We've sent everybody a letter to give to our GPs in case we need referral for pain, pins and needles and numbness. HealthLink continues to support anybody having difficulty obtaining this. With regard to any underlying nerve problem, as I've explained, Dr. Cowan is continuing to check everybody he sees for this. In addition, the Trust has asked UCL to include a test of the nerves in the blood pressure study, another reason why it's important for you to go to the study if you meet the criteria for the blood pressure. Hence again, currently we feel we're doing as much as we can to take this forward and be certain there's no new damage on the nerves with age. So finally, the work on blood pressure, how does this help us? If we have difficulty having a blood pressure taken in the upper arm, the Trust has already written leaflets to say the best way that this can be done. These are available via HealthLink, but are also on the website, and I've taken mine to my GP already. These leaflets have been shared across the world, for example, to Canada, Australia, and EDRIC. The blood pressure study will, as I've explained, help us as individuals know about our risk of heart attack or stroke and how this is best measured in the future. It will advise us whether or not we need to take tablets to reduce this risk, and if so, which ones are best for us to avoid the need to have blood tests to monitor them in the future. This advice will come from the best experts in blood pressure in the UK. The study will allow UCL to act as a specialised centre, not only for the UK and not only for limb damage caused from thalidomide. This means it will help other groups, such as those with TARS syndrome, etc., and it will develop an international reputation advising doctors abroad of different ways of taking blood pressure. The Upper Limb Project with Professor Trail helps HealthLink know how best to help us as individuals with thalidomide damage, how to help our GPs, and how we can get the best help from experts familiar with thalidomide damage, depending on how far we are prepared to travel. So, I have gone through what has been done and what is being done by the Trust and others to try to develop our knowledge of the health issues affecting us, and how this knowledge is used to help us. Knowledge is power. Information is liberating. If you have any questions, please email Dr. D. So, following that, thank you, trusted assistant. As I say, I'm not going to take questions now. I think Cole was very good at keeping up with me there. But also, I think linking on with this, I'm going to move and pass on to Dr. Mark Chulton, who's come all the way from Australia, New South Wales. He's going to introduce himself, but I think managing pain is a big issue for many of us. And I've already had a preview of what he's going to say, and it's really interesting. So I'm going to pass over to Mark.
First bit I'd like to say is a big thank you to the NAC and the UK Thalidomide Trust for actually inviting me over. It's a huge honour from my point of view, and so thank you very much for having me here. The other bit I'd just like to say as an Australian thalidomider, I'm absolutely jealous of you having the NAC and the UK Thalidomide Trust. We don't have anything like this in Australia. The facilities and the resources that you have are absolutely fantastic. So I am absolutely jealous. The first bit, this is certainly not a how-to guide. I'm really not here saying this is what you should do, this is the way to do it. It really is just to talk about my experiences both at a personal and a professional level. I'll introduce myself in a little bit about my professional dealings and experiences, but it really is just me talking about my experiences with respect to chronic pain, what I've experienced personally, what I understand professionally, and how I can try, or how I have tried to incorporate those two things in my own life. All right, first bit, I'm Australian. Don't hold that against me, I'm sorry. Any people from Scotland, I'm sorry. Okay. British, English, I'm sorry as well. Okay, we won't mention anything about the rugby from now on. Sorry. All right, the other bit, I've got a PhD in psychology. I'm a registered psychologist. Is that my area of research expertise was in chronic pain and disability issues. Unfortunately, I'm medically retired from being a lecturer because of my chronic pain condition. I retired officially back in 2009, so I've been a man of leisure since 2009. I'm still what's classified as a conjoint lecturer with the University of Newcastle, but that primarily just looking at marking theses and those sorts of things. One of the bits I was talking to someone else before is my upper limb problems are what I classify as my deformity. They're not my disability. My disability is actually my back. And the reason it's my disability is because of this. Well, pardon me. I've had 4 spinal surgeries for scoliosis. I'm never 100% sure whether the scoliosis was related to thalidomide or not. There's no one in my family. I think that it probably is. I can't say definitely, but there's no history of it in my family. So I have presently $80,000 worth of titanium in my back, 40,000 pounds worth, which I'm leaving to my daughter when I die. It's up to her how she gets it. I don't have to worry about that. She can get it and deal with it. But that to me is my biggest problem. That is my disability. It stops me from doing so many things much more than my arms ever have. Okay? And I think the other bit is that it's related to some of the issues that you'll all be familiar with is as we age, things get worse. Chronic pain, my spinal condition, gets worse. And that impacts me more and more. And that has I think that's a really important part. The psychological impacts related to that are a really important feature of chronic pain. It's a common thing for us as thalidomiders to experience psychological problems. That's not to say that we have diagnosable disorders, but we have psychological issues that impinge on us throughout our lifetime. that we have issues related to anxiety, we have issues related to depression. Those types of issues impact and feed back into chronic pain. So we can have a feedback mechanism whereby chronic pain leads to anxiety, which leads to depression, which then makes the pain condition worse. And I think really, from a personal point of view, is that my psychological state has a massive impact on how I deal with, respond to, and try to deal with my chronic pain condition. I'll talk about that a little bit later on in more detail. But suffice to say, one of the things that I've noticed in myself is that over the last 12 months or so, I have actually begun to isolate myself a little bit too much. I've realised by myself that I'm starting to pull back from the family, from friends, what have you, simply because I'm starting to find that I'm becoming more anxious and more depressed about things. Then that has an active part in me not doing as much exercise, which then means my chronic pain condition gets worse. What goes on in here is such an important part of how we deal with our world outside us, how we deal with our own physical conditions. The other bit I want to emphasise there is that feeling anxious and feeling depressed, having some of these issues, is not abnormal. It's a natural part of being who we are with our disabilities and our physical conditions, all right? I think it's very important for you not to think that you're abnormal, that you are outside of the norm. It's a typical thing that happens to people who have chronic conditions. My personal philosophy of psychology is the issue of self-awareness. It's not rocket science. I look at it in a very simple way, that we need to be aware of the thoughts that we have. What am I thinking to myself at any point in time? In other words, try to be aware of that inner voice, that little voice that's in your head saying, I can't do that, or I shouldn't do that, or if I do this, I'm going to hurt myself. I'm useless, I'm worthless. Be aware of what it is that you're saying to yourself, because what you say to yourself, what you remember about yourself, or how you look at your environment will impact on how you go about doing things. One of the nice bits I like about psychology is that you can change your thoughts, you can change your behaviours. Things are not set in stone. So whilst we may well have, and from personal experience, talking that I was isolating myself, that doesn't mean that I have to be permanently isolated. I can actively work to become less isolated. I can actively work to become more involved with people around me. I can start to look at what am I saying to myself? Why am I telling myself that I should be lying in bed? Why am I telling myself that I can't do this particular activity? Be aware, change the thoughts, and then you can change your behaviours. All right, a little bit more technical stuff is that pain is generally defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Pretty boring definition, but one of the bits I want to get from that, or talk about there, is that one of the big problems with chronic pain is that it's individual, it's subjective. Is that you can never ever tell anyone else really what your pain is like. One of the other problems associated with that is that quite often, because you might look okay, people won't believe you. One of my classic examples of giving a lecture to, who was it? I think it was medical radiation students, was that we were talking about chronic pain, and one of the first responses of one of the radiology students was that, well, what about if they're malingering? And I thought to myself, that was a really interesting perspective, because his first point of call was that the person was lying. Whereas my perspective was I will believe someone is telling me the truth until proven otherwise. Okay, so my belief is that if you tell me you're in pain, I'm going to believe you, and I'm going to try to do something about that. But the problem is there are going to be individuals out there who won't believe you. The other bit is that I don't know what normal is like anymore with respect to pain. I don't know, and I know that sounds a really strange thing to say, but I don't know whether am I really in that much pain or not? I mean, am I overemphasising it, or am I really totally screwed? I don't know. So it's once again, it gets back to that, what's going on in here has such an impact on how you feel and how you deal with your pain. Oh look, some other nice little statistics. All right, most thing to point out there is that chronic pain is a common problem. Okay, it's a chronic problem. 1 in 5 people will have a chronic pain condition. Okay, so once again, it's not just with thalidomiders who have this problem, it's a widespread problem out there in the community. It is an important issue with regards to employment or unemployment, a big issue with regards to economics as well, and more importantly, hospital services, facilities out there in terms of pain management services, the whole host of different issues. One of the other bits is that we really need to differentiate between chronic and acute, and I don't want to go into it too much, but one of the main issues that acute pain is that it's short term. The other bit about that, there's generally a light at the end of the tunnel. And psychologically that's important, is that when you think about that this will eventually cease, I will actually improve and no longer be in pain, is easier to deal with than chronic pain. The big issue psychologically with chronic pain is that when is this going to end? When is it going to stop? There is generally no light at the end of the tunnel, and that can be debilitating. That can be very, very difficult to deal with. You don't know when or if it will ever actually get better. Sorry? Yeah, exactly. Another important point. When it gets worse, will it get worse? Exactly right. That's a very important point. Blah, blah, blah. I don't really want to go too much into that. Yeah, one of the issues is that quite often chronic pain comes from acute pain. I know my own personal experience was that after my second spinal surgery, I would get intermittent pain in the back, which maybe would last for a day or two. And then one time, back in 1990... Ooh, no. 1885. No. Anyway, it doesn't matter. The time is irrelevant. At one point in time, it went from being intermittent, would last for a couple of days, to it's just permanent. I just went from one day, I'd have it for a couple of days and it'd go, to then I had it permanently, and I've had it permanently ever since. That's really hard. That's been really hard to come to terms with, is that, when you, as I was saying before, is that notion of having a light at the end of the tunnel, you can deal with it, but there are times when knowing that you've got something that is just not going to go away is very, very psychologically difficult to deal with. It's important to differentiate between those two from my perspective, and I'm probably doing this because I'm a psychologist, but it is because of the psychological aspects, okay? I'm referring back again, I keep going over the same ground, but it is that light at the end of the tunnel. You don't have it. Psychologically, it's a burden. I classify it too as sort of like that unwelcome friend that's always with you, is that it's always there on your shoulder. It's a bit like they talk about the black dog of depression. Well, chronic pain is a similar thing, is that it's always there with you, you can't shake it off. And then that once again leads into that issue of anxiety and depression. I think that bottom point too is really important as well, is that looking at the impacts in terms of the social and physiological and behavioural components that are associated with chronic pain, is that it gets back to, as I was saying before, is we can isolate ourselves, we can lose our social interactions, our interactions with our friends, our family, our workmates, what have you. And those types of relationships are very, very important. We all need a shoulder to cry on at times. We all need someone who we can offload our problems on. So the complexity of our personal relationships are also an important part of the issue of chronic pain. It was mentioned before of some of the studies that were from Sweden looking at lifestyle. Chronic pain causes changes in lifestyle. As I was mentioned before, one of my major lifestyle changes was the fact that I had to leave work. I could no longer work. And I used to enjoy lecturing. Didn't like the politics that went with university life or the administration, but I loved teaching, actually getting up and doing what I'm doing here and talking. I could probably talk underwater generally. I was always referred to as having verbal diarrhoea when I was young, and I don't think it has changed as I've got older. It's probably just got worse. But it caused that lifestyle change. It meant that I could no longer do something that I actually enjoyed doing. I lost something, okay? But what was happening is that the reason I had to give that up is that I was living to work, not working to live. I would go to work in the morning, get there at about 8 o'clock in the morning, come home at 5 p.m, and then basically I'd be in bed by about 5:36. Then I'd get up the next morning, I'd go back to work, do the same thing. Come the weekend, I might be up for a couple of hours, then I'd be in bed. And that was just unfair to my family. It just was not living. Is that I had a young daughter, and a young child needs their parents to be there with them, to be involved as part of their life. So I was getting to the stage where all I was doing was working. I wasn't living. I wasn't having a family life. So I had to make a choice. And it was a fairly easy choice, I suppose, with my last operation in 2007. I didn't really recover from that. But I did have to make that choice of saying, I can no longer work. I have to pull back. I have to make those lifestyle changes. I'm not going to go into a lot with respect to talking, or we'll touch on them a little bit later, about different types of processes and psychological methods such as cognitive behaviour therapy or acceptance and commitment therapy, which are approaches to dealing in a clinical manner with chronic pain. But what I wanted to talk about is that issue that when we talk about psychological approaches, they are managing your chronic pain. They're not curing it. Psychology doesn't offer a cure. We lost our magic wands many years ago. All we can do is allow you to learn techniques that you can use for you to manage your pain, okay? That's the main focus of any psychological approaches. If you ever go to a pain management clinic, and in Australia there are numerous pain management clinics run by different hospitals, is that the focus there is on we can give you, or they will give you, skills and techniques that you can use to manage your pain. You're not going to cure it, you're going to manage it, okay? Oh, pardon me for a second there. No, it's all right. I'll ignore that bit. Yeah, I've just referred back to that bit about the thoughts being really important, is that recognising what it is that you are saying to yourself is really important. Is that I know from a personal experience, as I was saying, with the self-isolation of things, is that it's just a case of starting to feel that I'm incapable of actually doing things. That, not so much that issue of hurting myself if I try to get involved with exercise, and that's an interesting point as well, which we can classify, or they classify as fear avoidance behaviour. But it's really a case of sitting back and trying to indicate to myself that I'm better off not doing something, I'm better off pulling back from people. And I think that that's a really important issue. Related to that is the point that if we can change those negative thoughts, you can change them into positive thoughts, you can then have the positive behaviour and the positive outcomes. The other bit, and this will be really important to a lot of us as thalidomiders, is that issue of past traumas, past life experiences. It's appropriate to everybody because we bring our past with us, we bring our memories with us. We bring our memories with us. We really are, our personalities or who we are, is based on our memories, is based on our experiences throughout life. And a lot of us, as thalidomiders, have had negative experiences, and those negative experiences become negative emotional experiences that can, once again, have an impact on your chronic pain, how you deal with your chronic pain, how you deal with issues of anxiety and depression. One of the bits that I certainly find myself doing, and I always think of that idea of physician heal thyself, or in this case psychologist heal yourself, is that often you can get yourself into a cycle, and I know I do this, where you keep thinking about the same negative thought over and over and over again. You get stuck into a negative loop. It's really important to be aware of when you're doing that so that you can break yourself out of that. Okay? Gets back to that philosophy of mine of being, psychology really is about self-awareness. Try to recognise those times when you are getting anxious. What motivates your behaviour? One of the things that I like in psychology, if you look at some of the theories of behaviour and what motivates behaviour, there are 4 basic motivations. There are only 4 basic motivations. My brain's gone into jello mode. We can look at sensory stimulation, we can look at escape avoidance, we can look at access to tangibles or attention seeking. When we think about those sorts of issues, is that we need, I suppose what I'm trying to say there, sorry, I've just got myself a little bit lost there. What I'm trying to say there is that we can understand a motivation for why we're behaving in a particular way, whether that might be we're stressed, we're angry, we're upset, what have you. If we can identify what the basic motivation is for behaviour, once again we can go through it and change that behaviour into a more positive aspect. Active self-management strategies is the terminology. And really, once again, what we're talking about is that issue of pain management. We're not talking about curative, we're talking about pain management, okay? We're trying to manage the processes, we're trying to manage the activities that we're engaged in, we're trying to manage our thoughts so that we can have the most positive outcome possible. I think one of the bits there is that last point is that what do I do when my pain does get worse? Do I start to think along negative aspects, or do I try to think about a more positive aspect? Once again, change the thought and you can change your behaviour, change the thoughts you can start to look at dealing in a more appropriate way. Blah, 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 I've said basically that before again. The notion of looking at engaging in negative self-talk is a really problematic thing to do. Recognising signs and symptoms of depression, I think, is a rather important thing for us to do. We need to look at those issues of different types of negative moods, looking at being irritable and frustrated when we're doing things, hard to take personal criticism, spending less time with friends and family, self-isolation, loss of interest in food and other activities, being awake. I suppose all I'm trying to say there is that try to be aware of what are the signs and symptoms of depression so that you can start to deal with those, so that you can try to seek assistance with those types of problems. Stress is another important issue. Is that one of the problems I tend to find with respect to the stress is that it comes out in physical activities as well. It comes out where you have those issues of muscle tension. One of the problems is that muscle tension in the neck becomes a real problem. So we need to find different ways in which we can deal with and overcome that. And simple exercises are a wonderful thing to do. I was just looking at one of the bits there of talking about we need to also try not to put too much pressure on ourselves with regards to trying to complete tasks. If we need to stop and take a rest, I think it's important once again to take that opportunity to have a rest. One of the bits that really is, and such a simple thing, is relaxation methods. is that learning to use relaxation, self-relaxation, self-hypnosis is an important skill to learn. There are lots of relaxation scripts out there that are freely available that you can go through and get yourself into. I suppose it's almost like a meditation state. And I find that that is exceptionally important when you are getting to that point of being anxious, being fearful, being run down. It's just very important, I think, for you to try to learn relaxation methods. Sleep is a really important one. I'm just trying to think, is the terminology that has been used is sleep hygiene. Learning appropriate methods and routines for sleep is once again an important bit. Reducing coffee, reducing alcohol, quitting smoking, the usual types of things. I knew I'd get a response like that. Once again, this is me saying what I do, not what you should do. I think the other bit is that trying to learn to do things slowly is important. Try not to do things like a bull at a gate. Try not to rush into things. Try not to put too much pressure on yourselves when you're going through and trying to engage in activities. I think the other bit is try to engage in activities that are meaningful for you as well. One of the little skills that you can try to use is timing yourself. If you do go to quite often, sorry, I'll start that again, at the pain management programs is that they quite often tell you to time yourself when engaging in activities. Sit down, literally have a clock, and every 5 or 10 minutes you get up and you walk around. One of the big bits is that sitting in the one place, like we're all doing here at the present point in time, is probably not the best things we could be doing for ourselves. We really need to try to make sure that we have breaks. Try not to put that pressure on yourself that you need to finish a task in a set period of time. Is the task that important? Okay. Pardon me, we've only got 5 minutes and I just wanted to bring out a couple of other bits. Simple exercises, just stretching is a really important thing to do. When you're sitting down at desks, that notion of every 5 or 10 minutes getting up and walking around, trying to do simple stretches on legs or ankles, looking at hamstring stretches. Obviously these types of things are going to be dependent on what we can do physically, but find what suits you in terms of doing some of those muscle stretches, some of those muscle relaxation processes. Finding equipment that you can use. There was earlier on one of the talks talking about access to different aids and gizmos. One of the things that can be useful is what's known as a TENS machine. I don't know whether you... Yeah, I thought there should be. Yeah. Yeah, it's one of the things that is individual. You need to find out what suits you. One of the bits is that it's individual. You need to find out what type of equipment suits you, what type of equipment is helpful. What I tend to find with the TENS machine personally is that it's short term, is that it's only going to help me during that point of time where it's on. It's certainly useful when I have muscle spasms for releasing a muscle spasm. Another simple piece of equipment is just this neck support. Once again, it's just lying down and stretching the neck, okay? So just simple things. Another one, an exercise bike. Just sit on the exercise bike. Pardon me, I think that's fallen down. Exercise bike, just do a short period of time if you're capable of using these sorts of pieces of equipment. Social support, as I've said before, is really important, and one of the problems that we can have is the issue of anger, and I know that was mentioned earlier this morning in the talk from Craig and Mikey, and yeah, we do have a large amount of anger within us, and it's understandable why we're angry about the processes that have surrounded our disabilities. But once again, we need to find ways in which we can deal with and cope with our anger. Of course, being around an angry person isn't generally the best thing to be. If we lose that social support, we lose those shoulders to cry on at times. And social support is absolutely important. And I think another bit, that last point, don't be afraid to ask for help. I know one of the big problems I have, and when I was over here in July with Lance, is he was going crook on me all the time for not asking him for assistance. And that is one of the bits, is that you do need to learn to ask for assistance. Don't be embarrassed by that. Don't feel as though you're weak. Nutrition is another important aspect, and I know I've only got a minute to go or I'm just about finished. Nutrition is an important aspect, one that can be easily overlooked. There is an issue related to called systemic inflammation, meta-inflation. And it's an issue that is related predominantly to Western diets, but it's easier said than done changing diets. It's lifestyle changes. All right. Seeing I think I'm about finished. It's supposed to be finished. I'll leave it there. I've had too much, I'm sorry.
I was just wondering what your opinion was, and I'm just solely speaking from my personal experience, of distraction techniques like comedy, music. I found at times where I was in a situation where medically there was nothing that was going to take the pain away, but it was something I needed to go through, therapy I was having. And I think that it was those distraction techniques when I sort of said, right, I've had enough, get me my music, give me my space, and I'm going into a different zone.
Exactly right. I mean, that's partly related to that issue of relaxation. It's just a different way of reaching that state of relaxation, is that distraction is really, really good. It's really important. There's also that notion of trying to, I'm just trying to think of the terminology that they use, where you more or less move out of yourself. And I think that if you can reach that state, it is really important. And that's really what a deep relaxation state is. So distraction is such an important process. And you can do that quite easily, as you said, by music. Okay, and I think it's wonderful. Yeah, no.
Okay, maybe one more question?
This isn't actually a question, it's just to clarify what I was saying to Mark earlier when he said about the TENS machine. For me personally, my experience with the TENS machine, even on the lowest setting, it actually made my pain worse. So it doesn't work for everyone.
Yeah, exactly right. And I think that gets back to the point I was trying to sort of say there, Hazel, is that we need to, with all of these types of things, find out what works for us, whether that be a TENS machine, whether that be using distraction through music, whether that be through reading. We need to find what works for us and use that. Don't take it that I need to use everything that I've been told. You need to try things and then find out what works for you and then do that.